My name's Maeve. I'm a GP and clinical lead with CEG. We also have Anna, who is our childhood immunisations lead, who'll be providing the update today. So in terms of housekeeping, the event is going to be recorded. Everybody other than the speakers, cameras will be off and they will be muted. You can unmute yourself to speak, but please keep yourself unmuted for the meeting. We will have questions at the end, which you can raise in the Q&A section, and slides will be shared after the meeting. So just a little introduction. Many of you already know us, but as the Clinical Effectiveness Group, or CEG, we're a group of GPs, analysts, and facilitators, and we're based at Queen Mary University. We access primary care data across NEL. We build dashboards and searches and tools for primary care. So today, we are covering an overview of the changes to the child immunisation schedule. We're covering the eligibility for the MMRV and implementation. We'll discuss ways that we can support you. We'll have frequently asked questions about the changes. We'll share some resources, and there will be the Q&A section at the end. So on to you, Anna.
Hi, can you hear me and see me and see the slides and everything? Yep.
Yeah.
Okay. So this is the very basic overview of the changes that, and you are probably very familiar with this already because some changes have been around since the 1st of July. Instead of presenting the changes broken down by when they started, I thought it would be more useful to present them now at this moment in time on who they affect to. So you've got changes that affect all children, which is the swap between the second B and the first PCB that already happened for the 1st of July, so you're aware of that. And the other thing that happens to all children, all children within the routine childhood immunization schedule, that is anyone who is under 6 at the beginning of this year, MMRV will be offered instead of MMR. So that's for everybody. The other changes affect children born on or after the 1st of July 2024, and that is the cessation of the HIPMEN-C, the cessation of Hep B vaccine at 12 months for babies at risk, and a new vaccination appointment at 18 months, which will be used to administer a HIP booster in the form of 4-hexa and an MMRV dose, which will be the second MMR-containing vaccine because they would have had already one at 12 months. So that's a very quick summary, but that was for children who are having their immunizations on time, the routine schedule. Children in a catch-up schedule have different you always have to check the UKHSA algorithm for children of uncertain status or incomplete status. It's very important that you check that, and if anything is not completely clear, then you need to also consult the Green Book or the PGD for the particular immunization you are having doubts about. Saying that, there are some things that are going to affect to everybody, and we've listed them here. One is that unexpectedly there's still stock for HIPMEN-C. It was supposed to be finished in the summer, but there's still stock. So children born before the 1st of July 2024 remain eligible for HIPMEN-C if they come up for their immunizations late. I don't think you are going to get a lot of them, but that is the rules that we've been told about. The other peculiarity is that any HIP-containing vaccine administered after the first birthday is enough protection. So this means that not every child will need a 4-hexa. So if a child started their immunizations late and they completed their 3-hexa course after their first birthday, they don't need this 4-hexa as a HIP booster. So it's not universal. Another peculiarity is that, and again, of course, this is for children that are very late for their schedules, is that if their fourth hexa as a hip booster is administered from the third birthday, it also acts as a preschool booster 4-in-1. So they are not going to need an extra preschool booster when 4 months later. And finally, and very similar to that, is that if a child had their 3 hexas in their first year of life, but then they miss their hip booster at 18 months, and then present for the preschool booster, they will be offered a 4th hexa rather than a 4-in-1, and that will cover both the hip booster and the 4-in-1 preschool booster. I know it takes a little bit of getting used to it, but it's not very often that it happens, which makes me repeat that you always need to check the algorithm to know exactly what they're due for. This is the table that UKHSA has published about MMRV eligibility, how the rollout is going to be implemented. It's a bit complicated, so I expect that many people are printing this because it all depends on groups depending on age or date of birth. So basically, there is a reference of the beginning of this month, and anyone who was under 1 year is going to be in the new normal, which is 2 doses of MRB at 12 and 18 months. But then there is a kind of like transition cohort, the children who were between 12 and 18 months, who are going to end up with 3 MMR-containing vaccines because they should have had already their 12-month MMR, but now they become also eligible for the 18-month MMRV and also the 3 years, 4 months. And this is absolutely fine. They can have 3 doses. It doesn't matter. There's not an issue with that. However, if they're late and they miss their 12 months, they don't have to catch up that. Then we've got a bigger transition cohort, which is the ones who are between 18 months and 3 years, 4 months at the moment. And of course, they should have had their 12-month MMR already. And they continue with the same schedule in the sense of timings, except that they will have an MMRV instead. And then we have the 3 years, 4 months to 6 years who will be offered, who should have been vaccinated already, and they will be offered MMRV catch-up from November. And again, they will end up with 3 vaccines if they had been on time. If they haven't been on time, then 2 doses is enough. And anyone who is under 6 is not considered to be under the routine schedule and is not eligible for MMRV, which I know it sounds a little bit strange. So in theory, you're supposed to keep stock of MMR for children who are older and also for adults who might need vaccination. This is we haven't had the reasons for this or how you're going to manage this. Is not something we can answer about. Some people found the UKHSA table a little bit confusing, so we created our own. We thought it would be easier to follow with columns in different places and some colors. So again, if you want to print this out, it's up to you. We've color coded who the changes affect to, and yeah, if you find it easier to follow, that's great. The reason I put it here is because, not just because you might be able to follow it better, but also to show you how the number of MMR vaccines and their staging, and when I talk about staging, I mean first, second, or nothing, or unstaged, it can become quite complicated. So we've got children who end up with, for example, you can have children who have an MMRV at 18 months, and that can be a second, or you can be a first. So it's all very messy. And NHS England has not given us a lot of advice on how to navigate this messiness. The only thing they've done is give us a 2-line recommendation, which said use the unstage code and use the second MMRV code, and they didn't mention the first, but they didn't explain how they expected us to apply this. So for our templates, we've pragmatically decided that we are not going to use stage codes. We're going to call everything MMRV, and that this makes it much easier when you are administering the vaccines. And at the end of the day, when we are measuring whether you had enough or not enough, all we need to do is to check, have you had 2 MMR or MMR-containing vaccines from the age of 12, separated by at least 3 months. And that's it. That's all that you need to know. It doesn't matter whether it says first, second booster, or nothing at all. So this is an example of what the new 1-year-old section of the template looks like. You've got at the top, you've got the 3 vaccinations that are you going to be given to everybody. But you still have the facility to record things that happen in the past, like HPMC or MMRV, or even the third pneumococcal if you are entering data from many years ago. Of course, you've got a new section for the 18 months olds as well, with the 4th hexa and the MMRV, and we give you a lot of information about what dates of birth are indicated for everything, and the same for the 3 years, 4 months. You have all the information you need to know what you need to code, depending on their date of birth. Well, not just to code, to give. There's some limitations with the template, and that's because some codes are just not available. So there are no decline or invite codes available for the 4th hexa. We requested them in the summer, and the request was declined by NHS Digital. We appealed, and it was declined again. And in the end, we were told that the reason for this is that NHS England are reviewing all the invite and decline codes. And until they decide what the new system is going to look like, they are not issuing any codes that are dose specific. So all we could do is put in the template a non-stage hexa code at 18 months, but that's all we could do. And as for the invitations, you can use generic invitations, just simply child immunization text message sent, for example. With MMRV is different, because we have heard that there was going to be new decline and invite codes coming in December, but this didn't happen. And then I thought, well, they'll surely come in January. And I checked yesterday, and they still haven't come. So really, we don't know what's going to happen. Some people have asked, well, what do we do in the meantime? If someone declines, all I can suggest is that you use an MMR decline code for now, until NHS England says anything else. Of course, we have got a lot of, we've got our call recall tool, the Apple Imms version 5. There's been a lot of work to get to this version, but you shouldn't notice many changes. You will notice some cosmetic changes to make it remain in brand with our new web-based tools. By the way, we will do the Apple Imms in web-based at some point in the future as well, but it's a very big project, and I can't really give you a date for that yet. In case you don't remember, there is a facility called the Quote of Last Chance, and if you run this monthly, you can try and pick up children where if you don't do something that particular month, then you will never be able to do it. And if you look at your Quote Income Maximizer dashboard, you will see that that you are probably losing a lot of Quote money in child immunizations. We're not saying that this is going to help you get it all, because there are many challenges to getting the Quote metrics, but it might help you in some cases. And if you find anything using the tool that you find weird, it's like, why is this child included here or not included there, or whatever, always contact your facilitator. Most of the times there will be an explanation, something like similar to what I explained at the beginning, like when someone doesn't need a for HIP or need a hexa instead of preschool booster or something like that. But if there is something that you're not clear at all, just always contact your facilitator, who will be able to investigate and let you know why you are seeing what you are seeing. And well, there's also the chance that it could be a bug, and if there is a bug, we want to know it as soon as possible so that we can fix it. Remember to download the new version, and remember that you can look at the user guide, the videos, and other guidance documents in our website. Remember, we also have a dashboard, the CEG Timely Childhood Immunizations dashboard. I mean, most of you are probably very familiar with cover dashboards. This is different. Cover dashboards are very useful for benchmarking with a country, at national level, and even at world level. But they are not useful for everything. They're not very good at spotting trends quickly, for example, and they don't help you vaccinate children timely. If you're vaccinating children in accordance with the cover schedule, you're always going to vaccinate them too late to protect them when they are their most vulnerable. So the CEG Timely Childhood Immunizations dashboard focuses on vaccination as close as possible to the ideal time, so that vaccinating the children when they are most vulnerable to disease, which is when they are at their youngest. And I mean, that should help you work towards better cohort results as well. And the other good thing about this approach is that you can spot performance deterioration in time. You don't have to wait a year to realize that you're not on the right track. But conversely, it also can demonstrate improvement very quickly. So if you're doing a quality improvement intervention, you can demonstrate that your intervention has had a positive outcome. I mean, we were able to demonstrate this very clearly last year when there was a very bad measles outbreak in Hackney, and our dashboard and they did a wonderful response with the catch-up vaccination campaign, and it was really an effective campaign, and the effect could be seen straight away in our dashboard, whereas cover will not reflect that impact till next year. It also allows you to benchmark yourself against NEL, your place, PCN, PS, etc. It helps you to measure the burden of hesitancy. You can demonstrate that you've got lots of people, lots of children, well, lots of parents actually refusing vaccinations. It's something that you can tell CQC, for example, if they ask you why your uptake is not as good as they would want to see it. And the data is refreshed monthly, and you can find it in the usual CEG dashboard hub. There are lots of frequently asked questions on MMRV, and I've listed here some of the most common ones. So only MMRV will be offered within the program. Remember, the program is for anyone who is younger than 6 on the 1st of January this year. So no MMR and varicella separately will be offered, and that is the way it is. You cannot give one or the other, just MMRV. There is gelatin-free available, Priorace Tetra. MMRV can be given alongside other live vaccines, except yellow fever. But do remember that, as with MMRV should not be given to immunosuppressed or pregnant individuals. The minimum gap between MMRV doses, again, is 4 weeks, same as before. Anyone older than 6 years on the 1st of January 2026 is not eligible for MMRV. So if someone comes, if an adult or an older child comes for MMRV, you actually have to give them MMR. However, they said if you don't have any MMR available in the practice, and you don't think they would come back to get vaccinated on another day, then you are allowed to give them MMRV. That's the advice. You don't have to worry about cough. The MMRV codes, including the and stage 1, are already accepted in the cough searches as they are now, and they are already written in such a way that doses given at 18 months are accepted. So that is not a worry. It is safe to give MMRV to a child who has already had chickenpox. It is safe to give more than 2 doses of MMR-containing vaccine. And the Oxford Vaccine Knowledge Project has resources to help you talk to parents who are hesitant. And those resources are linked from both our template and from the Apple Imms Call Recall 2. So make sure that you check them out, because they can be very handy to just like send links on text messages to parents, for example. They are very comprehensive. And now I've got an exercise. I appreciate that not all of you are vaccinators, some of them, but I think even for people used with who are involved with administration, it's useful to have an idea of how these things work and to try to work out how would you do this. So do I have a volunteer to talk me through this, to tell me how they would do a vaccination plan for this example child? Do I have someone? Raise your hand. No? Okay. Okay. Well, we'll go through it anyway. So we've chosen a 5-year-old child, just arrived from India, and they've got evidence of 3 doses of DTWP, Hep B at 6, 10, and 14 weeks. Then they've got rotavirus, then they've got PCV10, and they've got FIPB. Those are the primary immunizations. Then they've got, at a later date, they've got, at 9 and 60 months, they've got MR and DTWP. Have you noticed that some of these vaccinations look different to ours? Not just that they are given at different times, but they look slightly different. They are not typos. This has been typed correctly. So where you see DTWP, that's because it's not diphtheria, tetanus, acellular pertussis, is whole pertussis, for example. And FIPB is fractional inactivated polio vaccine. And PCV10 has got 10 ingredients, addresses 10 diseases rather than 13, like our PCV13 that we give in our normal schedule. And the most curious thing, interesting thing, I think, is the one at the top, DTWP Hep B. Do you notice what's missing there? What's missing there is the polio. So it's a 5-in-1, but it's not a 5-in-1 like we used to have in the old days in England. It's a 5-in-1 without polio. This is quite critical because you shouldn't code this as one of our old vaccines, because you would be saying that this child has had a polio vaccine there and they haven't. The other thing is this 5-in-1 is not going to get you to do any QoF points. But then again, it doesn't matter because this child is too old to be in a QoF cohort. So those are some of the things that you have to think through before you do your vaccination plan. So the answer is, what you have to give them is right now is an MMRV for several reasons. One is because they never have MMR. If you remember, they had MR but not MMR. So even if we had not moved to MRV, they would need an MMR. And the reason they need MMRV rather than MMR is because they're still 5 years. They're not over the eligibility criteria. So you would, and the third reason is that their first dose that they were given, that MR, even if it was an MMR, it wouldn't be good enough because it was given at 9 months. So that's not protective. Anything given, any MMR given before the age of 12 months. So that's the reason for that. And then you will give them a hexa, and you will give them this hexa for several reasons. One is because they have not had a high booster. The other one is because they are due for their preschool booster. And the other interesting one is that they needed a polio booster anyway, because what they had was fractional IPV, which UKHSA tell us that gives a lower immune response, and therefore they need an additional dose of whole IPV. And that's the advice that we get from the algorithm and from the Green Book. And then after 4 weeks, you will give them another MMRV to complete the course. They haven't had any meningitis B or PCV, but because they are too old for that, we don't have to worry about it. And even if they were under 2, then you would offer them a dose of PCV13 because they only had a PCV10. We've got lots of resources. There are lots of resources to support you. Some of the resources are our own guides, guide to changes, guide to gaps between vaccinations, guide to frequently asked questions for cough. And I think that runs to 4 pages because there are so many questions about cough. And then obviously you've got NHSE and UKHSA resources such as the new schedule, an eligibility calculator where you can put a child's date of birth and it will tell you what they need to have. Unfortunately, it will not work for catch-up, so it's sort of limited use in that sense. I think you have to be very, very careful when you use it. And there is also very good information on the changes, and of particular interest for nursing practitioners is the MMRV program information for healthcare practitioners, which has a lot of questions. And you also have a recording and slides of the webinar on changes that was at the beginning of this month, I think it was, or something like that. And of course, always remember to contact your local practice facilitator who can support you with any of this.